Hello, and welcome to our Facebook Live broadcast with Capital Digestive Care. My name is Janine Hu, and today we will have a real talk about colorectal cancer prevention and screening. Colorectal cancer is now the second leading cause of cancer deaths in both men and women in the United States. But thankfully, it is one of the most preventable types of cancer thanks to screening. I'm joined today by three expert gastroenterologists from Capital Digestive Care. Dr. Harish Iyer from our Suffolk office, Dr. Oladba Okoji from our Rockville office, and Dr. Stephen Park from our Rockville, Iamsville, and Frederick offices. Stay tuned to hear more, share this broadcast with your friends, and if you have any questions for our experts, leave them in the comments below. We will answer them during the broadcast. Thank you for joining us. Dr. Iyer, let's start with you. What exactly is colorectal cancer?
Thank you for the opportunity, and I'm glad to share this platform with my colleagues, and hopefully we'll have a healthy discussion and enjoy our time that we share with our patients and friends and family. So as you said, colon cancer is a very common type of cancer that we are seeing in the United States. Like you said, it's the second most common cause of cancer-related deaths in our country. It basically, the colon or the large intestine or bowel, as it's called, it comes towards the bottom part of the digestive tract, and it's mainly used to take care of the waste products that we eliminate out of our body. Now, cancer is a generic term used to describe any growth of cells that can become distorted, which can become uncontrolled. So any type of cell in the lining of the colon that may have a tendency to become precancerous and then to cancer can lead to this condition called colon cancer. Now, one of the myths that I want to bust here is that there's a perception in the community that colon cancer affects certain groups only. It doesn't affect men or it doesn't affect women. Unfortunately, it's an equal opportunity cancer. As we've seen, it affects celebrities, affects people in low socioeconomic status. You probably heard about Chadwick Boseman recently, Pele, the great footballer. All of them succumbed to colon cancer. But as you rightly said, it is preventable for the most part, in the vast majority of cases, by getting colonoscopy or doing another type of screening test to check. And by removing precancerous polyps, we can prevent this cancer more often than we are currently doing.
Great. And Dr. Okoji, can you tell us more about who is at a higher risk for colorectal cancer?
Sure, absolutely. I mean, like Dr. Iyer said, everyone is at risk, but there are certain populations and certain ethnic groups that are do have a higher incidence in terms of survival and mortality. And when you're talking about ethnicity, it's highest right now in American Indian and Alaska Natives, and this is probably compounded by inadequate availability to endoscopic services. And next you have African Americans or non-Hispanic Black individuals who have the highest incidence in terms of survival and mortality. Racial disparities are seen more among men when it comes to mortality, and in general, lower socioeconomic status does seem to sort of play a role in that higher risk as compared to people from a higher socioeconomic status. And that may have to do with the prevalence of colorectal risk factors or sort of more likelihood of colorectal cancer risk factors, including smoking, obesity, and just screening uptake. A family history of colon cancer or a family history of precancerous polyps in an immediate family member who was diagnosed before the age of 60, that person should absolutely be assessed for a colonoscopy by age 40 or 10 years younger than the age of the diagnosis of the youngest affected relative. Genetic risk factors. So these are things where you end up sort of like getting either a genetic analysis or genetic testing because of your family history, either due to another type of cancer or colon cancer. So when I'm referring to that, I'm referring to things like hereditary colorectal cancer syndromes like Lynch syndrome or FAP, which also stands for familial adenomatous polyposis, I'm sorry. And so these are things, like I said, genetic risk factors, and you would need some form of genetic testing to find out about that due to a family history or a family history of multiple polyps, for example. personal history of radiation to the abdomen, pelvic areas to treat prior cancer can also be a risk factor. And then chronic inflammatory bowel disease like Crohn's or ulcerative colitis, especially if it's untreated, just for the pure fact that chronic inflammation increases risk of cancer, increases risk of colon cancer. And then lifestyle, this is like a big thing for patients when we talk about it. It's like, what can I do to sort of make sure that my risk is lower? Obesity was recently shown to be associated with all major subtypes of sporadic disease as it relates to colon cancer. Reduced dietary quality. So when I say that, I mean basically a diet high in animal fats, diet high in processed foods and sugars, diet low in fiber, and by virtue, diet low in fruits and vegetables. And then if you have a diet that's very high in smoked meats and fishes, that certainly increases your risk of colorectal cancer. And then smoking, smoking cigarettes, the use of tobacco, overconsumption of alcohol. What I usually tell my patients when we talk about lifestyle stuff is I say, whatever's good for your heart is good for your colon. If you're going to take care of your heart, you're taking care of your gut. Exercising also, is also a positive thing you can do to lower that risk factor. So it's not all inclusive, but these are some of the things that certainly do increase your risk for colon cancer.
And Dr. Park, what are the symptoms that signal to someone that it's time for them to see a gastroenterologist?
Sure, right. So the typical symptoms of that would be concerning for a colorectal cancer may include blood in the stool or toilet bowl or with wiping, as well as the change in one's bowel habits, and which may include either the frequency or the caliber of or both of the bowel movements. Patients may sometimes describe that bowel movements become smaller or more thin, irregular, or a sensation of them being incomplete. And other possible symptoms that could be associated with the colon cancer may include abdominal pain or unintentional or abnormal weight loss. Lab work could also potentially show anemia or low blood counts as also a possible red flag. So it's important to point out that these symptoms are more often seen in later stage colon cancers. And actually the majority of early stage colon cancers actually don't have any symptoms at all. Overall, this would further highlight the importance of getting screened, as the goal is to prevent any symptoms or cancer from forming in the first place.
Great. And Dr. Iyer, why is colorectal cancer considered one of the most preventable forms of cancer?
Excellent question. As Dr. Park was saying, certain types, when colon cancer reaches a certain bulk or certain mass, it starts producing symptoms, but the vast majority of patients will not have any symptoms. Now, the beauty of our profession is that we can intervene and prevent this from happening. On an average, the vast majority of colon cancers will come from polyps that are allowed to grow over time. On an average, it takes about 10 years for a polyp to form and for it to become colon cancer. So you have this lead time of about 10 years or so where you can intervene. Now, in these stages, when you have these polyps, you have no symptoms, which is why a broad-based screening strategy, not waiting for symptoms to occur, but age-based or risk-based is appropriate so that we can not only detect these cancers, we can prevent colon cancers by finding these polyps and taking the polyps out. I tell my patients in a simple way, I tell them, think of these polyps like small petty criminals on the road. You want to take care of the big gang warlords and all. Yes, that's the cancer. Most petty criminals will not become warlords, but the warlord is probably a petty criminal at some point that was allowed to grow. So take care of the small things, and over time, the big things take care of themselves. So we also have excellent tools at our disposal to find these polyps, take these polyps out in a safe way. In Capital Digestive Care, we have fellowship-trained, board-certified gastroenterologists who do this day in and day out. We do several thousand colonoscopies and several thousand polypectomies every year. And it has been shown that by doing regular colonoscopy, by taking these polyps out, we are actually impacting the incidence of colon cancer. We're reducing it, one day at a time.
Great. For those of you who are just now joining us, welcome. Please remember to like, comment, and share this broadcast with your friends and family. If you have questions for our panel, please leave them in the comments below. We will answer them during the broadcast. Now, Dr. Okoji, when it comes to colorectal cancer screening, experts say that 45 is the new 50. Could you please explain what this means?
Yeah, absolutely. So what we've been seeing over the last couple of years is that colorectal cancer is now being diagnosed earlier, and that 1 in 5 colorectal cancer patients are between age 20 to 54. Every 3 years, the American Cancer Society provides an update of stats based on incidence from population-based cancer registries and mortality from the National Center for Health Stats. And so, for example, in 2023, they're predicting about 150,000 individuals will be diagnosed with colorectal cancer. About 35% of those patients will unfortunately pass from colorectal cancer. And in that same group, 19,000 individuals would be less than 50 years of age. There was a shift to left-sided tumors, as Dr. Iyer, or as Dr. Park brought up, with the proportion of rectal cancer increasing from 27% in 1995 to about 31% in 2019. And we're seeing this, like Dr. Iyer said, we're doing thousands of colonoscopies every year. And so we're seeing younger patients who are coming in, and we're seeing larger polyps, more advanced polyps. And we're so glad that they showed up. We're so glad that they came in for that rectal bleeding that didn't seem to go away. So although colorectal cancer mortality declined by about 2% annually from 2011 to 2020 overall, but in that 50 individuals less than 50, there was a 0.3 to 0.5 annual increase or in individuals in the younger population. So all in all, this is sort of what we've been seeing over the last 3 to 5 years, and it really has a lot of societies, especially the GI societies, have really recommended and pushed, and the American Cancer Society promoting this as well to decrease that screening age from 50 to 45. And so indeed 45 is certainly the new 50. And if you have other risk factors, other family history, that age might even have to be lower.
Those are some pretty alarming statistics. Now, Dr. Park, do we know why colorectal cancer is being diagnosed earlier? For example, are there any lifestyle or environmental factors that we're aware of?
Sure. So yeah, and one thing I wanted to point out when Dr. Koji just touched upon it. So yes, in the younger patients whom we have been seeing the colon cancers, particularly under 50, we have been seeing more. They often are symptomatic, meaning they will have some bleeding or some other bowel habit changes, as we were discussing. So it's important to just make sure you don't ignore any symptoms and just make sure you get checked. Now, to get to your question with regard to possible reasons for this concerning trend, I mean, there's not one specific or clear-cut reason that we are aware of. It's likely multifactorial, and Dr. Koji touched upon some of these earlier. Between genetic factors as well as environmental and some lifestyle choices as well, they all may be at play in concert. So, for instance, it's estimated that about 35% of younger onset colon cancers may be linked to hereditary factors or syndromes. It's therefore even more important to be aware of family history of colon cancer and advanced colon polyps, particularly in first-degree relatives such as parents, siblings, as these patients may need to be screened starting even earlier than age 45. We've seen other risk factors that link to earlier colon cancers, including obesity, hyperlipidemia, or high cholesterol, as well as a history of high blood pressure, chronic kidney disease, inflammatory bowel disease. And possible lifestyle risk factors include significant alcohol use, smoking, a sedentary lifestyle, and a diet that's higher in red meat. So overall, it may not be one specific reason that we can pinpoint. Most likely, it's related to multiple factors, and more research is certainly needed on this subject. In the meantime, the best one can do is to be aware of your risk factors, try to minimize them to the best of your ability, and be sure you get screened on time.
Great. And Dr. Park, we received a question from an audience member who would like to know, is screening covered by insurance?
Yes, so the great news is that in general, a screening colonoscopy is covered by insurances as a preventive care service. So this would be similar to in women, getting a mammogram or a pap smear. So yes, in general, it is covered. But now with any specific questions on regarding specific coverages for services, I always encourage patients to contact their insurance carrier. But the good news is that this is classified as a preventive care service.
That's great news. Now, a colonoscopy is referred to as the gold standard for colorectal cancer screening. Dr. Iyer, can you please explain why?
Yeah, so there are several options that you have when it comes to how you would want to get tested for colon cancer. You could do stool-based testing, you could do a colonoscopy, you could do a CAT scan. All of these are acceptable options, and we'd encourage you to discuss these options with your providers. But having said that, colonoscopy is the only test that both detects and prevents colon cancer. And any of the other tests, if they were to pick up any of these abnormalities, it needs a second step, which ends up being the colonoscopy. By default, it is what we would use to define as the final say. It's got excellent sensitivity and specificity, meaning that it is less likely to have any colon cancers that are missed. And once it diagnoses it with a certainty, because we can take a biopsy sample, we can confirm that under the microscope with the help of a pathologist. So for all of those reasons, it's considered the gold standard. Now, we may be a little bit biased based on what we're seeing, in that we would encourage patients to get the colonoscopy, but any test that screens is a good step. So most important thing, I think, is to get screened. If you get a colonoscopy and if you get it done with, one of our gastroenterologists who are, like I said, fellowship trained, board certified, and we also have metrics that we follow to make sure we are maintaining our expertise in these steps. We've seen historically that, compared to national guidelines, our gastroenterologists tend to find a lot more polyps. And the more polyps we find, we can prevent even more patients from getting colon cancer.
And Dr. Okoji, despite the benefits of getting a colonoscopy, a lot of patients are reluctant to get the procedure done because of the prep process. What is it about colonoscopy prep that some patients find difficult?
It's the prep process. I always tell people it's not fun, and we don't advertise it that way. It's a necessary evil to set to a life-saving reward, and what I always tell patients is, like, you can't swim in a muddy pool. You sort of need to kind of clean out the pool, get the chlorine out, make it super clear, and then you can take and then that whoever's looking for stuff can then look at it and make sure that we remove these polyps that Dr. Iyer talked about, so that we can prevent further growth of polyps into colon cancer. So, I mean, the prep itself is cumbersome. It does take something out of you. You have to not eat for a whole day. Most people will have to do what's called a clear liquid diet. In some cases, we do allow patients with, certain medical issues to maybe have like a small meal, a small sort of restricted meal the morning of their prep. But that's, it really depends on the patient. But in general, everyone's on a clear liquid diet, which they essentially, can't really eat anything substantively or solid. It's really clear juices, apple juice, broth. We'll give you a list of what's allowed. And then the evening before your colonoscopy is when you start the prep. There are now pill-based formulations. It is dependent on your insurance carrier, but pills are an alternative to drinking liquid. And, in the past, a lot of the liquids were really large volume preps that people had to sit there and just drink and drink and drink. And that was just very hard for them. But all our preps, especially within Capital Digestive Care, are small volume preps. So you're doing no more than 12 ounces. And we do all our preps in what's called split doses. And we all taste them. I think for the most part, all of us have tasted it to some degree. So we know what they taste like, and I will say that the preps probably taste like a little bit of salty Pedialyte. I think that's the worst taste that I can think about it, But in general, you drink that the night before, and then you do another dose 5 hours before your procedure. And the difficult thing is that we're making you have diarrhea. You're essentially cleaning out all the stool so that when myself, Dr. Parker, Dr. Iyer do the colonoscopy, the lining of the colon is clear. We see everything. There's no stool, there's no sticky stool, there's no solid stool. And that way we can be confident that we are looking and removing all these polyps that we're talking about that do increase your risk of colon cancer. So as I said, it's not a fun process, but it's very doable. And I do think that the preps that we have available are certainly much easier than they used to be. And there are different things people do. They freeze it, they make slushies out of their preps. And like I said, the pills are also an alternative. And this is what we'll talk about at our visit. You know, if you end up having like a pre-colonoscopy visit, we can talk about different things and ways to kind of make it more palatable, you know, and hopefully make it a successful and less anxiety-provoking process.
Yeah, I tell them it's not going to make it to the beverage aisle, but it's an important part, and it's probably the most important part. I think we'll all agree on that it is probably the most important part of the whole process.
Yeah. And I also do tell my patients, I'm like, listen, you don't want to come back and do this just because your prep wasn't good, right? So give it your best, you know, give it your best. And we talk, you know, if the issue is sort of feeling nauseous or gagging, we'll work through it. You know, we'll pull all kinds of contingency plans so that we get through it, so that you can be sure that the person looking got the optimal and best look possible.
We also often hear that some patients feel self-conscious or embarrassed about having a colonoscopy. Dr. Park, what would you say to a patient who feels this way?
I would say that, well, this is certainly understandable given the sensitive nature of the exam. The key thing to remember, though, is that this is all about, you know, your health, your well-being, as this is a potentially cancer-preventing and life-saving procedure. I would recommend asking questions and discussing any specific concerns with your healthcare provider or team prior to the procedure, whether that be during the pre-procedure clinic visit or even the day of the procedure. Just remember that the staff involved in helping to perform your colonoscopy are all professional, highly trained and very experienced. They'll do their best to make you feel comfortable and informed about what is going on that day. And in addition, the nice thing is that during the actual colonoscopy itself, in general, with the medication you receive for sedation, you will not be awake or aware of anything during the procedure. So some patients actually say the nap that they get to take is the best part. So there's also that to consider as well.
And Dr. Iyer, can you walk us through the process of getting a colonoscopy once a patient arrives for their appointment?
Absolutely. Now, after they've done their hard part, which is the bowel prep, as we discussed, you know, there's usually a little bit of paperwork or checking in process at the front desk. And our check-in staff understand, you know, patients are anxious. Patients are hangry sometimes. They've been awake all night. They've been doing their prep. So we try to do our best to make it as expeditious as possible. But there is a little bit of paperwork that has to go in. And as much as patients, you know, don't want us to keep asking the same questions over and over again, we do have to make sure that we're checking their allergies and making sure that they've, you know, not consumed any liquid right before their procedure. It's to keep them safe. So there's a small amount of, you know, questions that go on before the procedure has to be started. And after you've had a chance to ask any questions to your anesthesia provider or to your endoscopist, you will have the consent form or consent process taken care of so that you have had the opportunity to have any lingering questions or any concerns or anything that you may want to address with these providers. You typically change into a gown where in which the procedure will be done. A quick IV line is placed. The medication is usually given through the IV line. We're going to check and make sure that your blood pressure is okay, your blood sugar is okay, all of those things that you typically do. After you're ready, when your time is ready, we'll roll you into the room where the procedure is done. We usually hook you up to a bunch of monitors to monitor your heart, your lungs, your breathing, because the sedation does require us to keep a watch on all of those parameters. Typically, the procedure can take anywhere from 15 to 20 minutes. Most of our endoscopy centers also use carbon dioxide for insufflation. The colon's like an accordion. So normally the colon starts off being small and we have to insufflate it. We have to expand it with either air or carbon dioxide. Now, you may have heard stories, and some of our viewers may have had stories where their family members may have had colonoscopy. There was a lot of pain after the procedure. They had to pass gas. Now, we are trying to move most of our centers, if not all, to using carbon dioxide so that it becomes a truly painless experience. In my doing this for so many years, using the sedation to kind of keep the patient comfortable, using carbon dioxide to make it a pain-free experience has usually, revolutionized what we do for our patients. Most patients, like Dr. Park said, wake up after the procedure and say, hey, when are you going to get it done? And we tell them, well, you're done. Two most common questions I get: can I get more of the medication? It was the best nap I ever got. And the answer is usually no. And if they don't complain about the prep, I'm like, did you actually take it? So I do expect it to be a somewhat of a dramatic, so to speak, evening the night before when they're prepping. So, I would just say, I hate to use this joke, but go with the flow.
And then a lot of people say that wasn't so bad.
Yes. So when they say it's not bad, I'm like, are you sure you took the whole thing? Because I'm used to so much complaining and I get it, I get it. It's not fun, but most patients, they understand the importance of it. They understand why we have to do it. And, they're usually, once they're done, they're like, you know what, it wasn't that bad. It wasn't that bad. So I think the anxiety and the fear and the unknown usually is worse than the process itself. Prep is not fun, but like you said, it's the necessary evil to get so that we can take care of you.
Right, just don't make any big plans the night before.
That's good advice, Dr. Park. We received a question about prep from our audience. What medications are used for sedation and what are the side effects?
For the prep or the sedation, sorry?
For the sedation.
Very good. Most of our centers will use a light sedative. Yeah, we call it anesthesia, but it's like a light sedative. Most common agent that we use is something called propofol. It's a short-acting agent. It gets in fast. Within about 5-10 seconds of the anesthesia provider administering the medication, you're off to sleep. I joke to all my patients and tell them, you let me know when you're asleep. And, that usually ends with a chuckle. And before, they wake up so much refreshed. It's almost like a very refreshing sleep. We used to use medications like Versed and fentanyl before. We've sort of backed away from that. That used to get patients a lot more side effects afterwards, like being groggy. But when we use propofol, for the most part, the patients are awake. They are back to, without any major issues whatsoever. We do advise patients not to drive the day of the procedure or make any important medical decisions. But the sedation is usually fairly straightforward. That's been my experience.
Right, and a common question that also comes up is with the sedation, is it the situation where I'm going to potentially wake up in the middle? Will I be aware of anything? So some of the medications that Dr. Iyer mentioned that were formerly more used, such as the Versed and the fentanyl, that is more so what we call moderate or conscious sedation, more like the twilight, where patients, it's possible they may wake up in the middle or just, or feel some things. But, as Dr. Iyer mentioned, propofol, which is now typically what all our endoscopy centers are using. In this scenario, the patients are typically asleep or you're out, and the next thing you know, you're waking up and the procedure's done, which is generally speaking how most patients would prefer it. So yeah, and then as Dr. Iyer mentioned, the effects of the medication are very short acting. So people are not drowsy or, tired the rest of the day from the medication itself, typically, as you'll be walking out of the procedure center that day yourself with hopefully a big smile on your face.
And we have another question from our audience. What is Cologuard and is it an effective way to screen for colorectal cancer? Dr. Okoji, would you like to answer this one?
Absolutely. I believe Dr. Iyer and Dr. Park brought Cologuard up a couple times. But in general, Cologuard is a stool-based screening test for colon and rectal cancer. So the colon sheds cells from the lining every day, and these cells pass with the stool throughout the colon. The cancer cells may have DNA changes in certain genes, and Cologuard detects this altered DNA. So the presence of abnormal cells or blood in the stool may indicate cancer or precancerous tumors. So in general, it is a really good screening test. But I always counsel patients that it's a good screening test for the average risk patient. So if you fall into that category of having, either family history or other risk factors that would increase your risk of colon cancer, it may not be the right test for you, because you may miss polyps that maybe aren't secreting any of that altered DNA, and you may get a false negative. Whereas the colonoscopy allows us to basically, not just as a gold standard test, allows us to look and remove. So we're able to remove polyps that are benign and maybe might be on that path to becoming sort of more precancerous. but by removing it at that early stage, we're able to prevent that from happening. And that's how we essentially prevent death from colon cancer and decrease mortality from colon cancer. Every positive Cologuard does have to be followed up with a colonoscopy, because that's the gold standard. We want to basically investigate why that Cologuard stool test was positive. So there are lots of positives to it, but not necessarily negatives. I do think there's a nuance in sort of the right patient for Cologuard screening, and that's a conversation that we'd be happy to have with you in the office, or with your primary care doctor, and making that decision. If you do have a negative Cologuard test, you can do another one 3 years later. And in 3 years, if you decide to go ahead and do a colonoscopy, that might be appropriate way to sort of follow things up. One thing I found with Cologuards, especially positive tests, is that it does increase some anxiety, because patients are coming in for their follow-up colonoscopy, worried and anxious about a positive test that may end up either being a false positive or, thankfully a polyp that we could just remove before it had an opportunity to become any kind of pre-malignant lesion. So I do think it's a good screening test. I just think it's a good screening test in the appropriate patients, and should always, be done after a discussion with the clinician, either your gastroenterologist or your primary care doctor.
And Dr. Park, while we're on the topic of alternative screening options, are there any other effective screening tools that are available?
So yes, there are other alternative options for screening. We touched upon some of them. Now there's a stool-based test. In addition to Cologuard, as Dr. Koji was just discussing, which is every 3 years. There's also fecal immunochemical tests and occult blood tests, which essentially assess for hidden blood in the stool. These are actually done annually. These tests are a bit older than the Cologuard, and typically the best stool test is considered the Cologuard at this point. In addition to those, there's also something called CT colonography, otherwise known as a virtual colonoscopy. So this actually uses CT scan data to construct images of the colon. This is typically done through radiology. It still does involve a bowel prep and insertion of a tube up the rectum. However, for this one, there's no sedation actually. So with this exam, and it's often more uncomfortable, people may say, compared to the actual colonoscopy where you do receive the sedation. So this is mainly best for detection of larger polyps and lesions. So smaller ones or smaller polyps may be missed. And this would be every 5 years. Now, another option that is approved is something called a flexible sigmoidoscopy. So this, in essence, is considered like a partial colonoscopy, where the last couple of parts of the colon are looked at, with the scope, the sigmoid and the rectum. This involves a less intensive bowel prep, maybe with or without sedation. And at times as well, it may also be combined with one of the other stool tests that I mentioned previously. So while it's an option, it is not commonly recommended these days, as polyps and cancer may actually form in any part of the colon. So as we've touched upon, it's important to note that any alternative test that comes back abnormal does need to be followed up with a colonoscopy. So as we've noted, colonoscopy is still considered to be the gold standard for screening as both a diagnostic and a therapeutic procedure, where polyps can not only be detected, but also removed that same day. And this also does allow us to detect smaller and earlier lesions as well and remove them for prevention. So yeah, overall, if you're still hesitant about getting the colonoscopy, it's important to note that any screening test is better than no screening test. So it's very important to discuss with your healthcare provider as to what options may be best for you.
I agree.
Great. Let's
Summarize
answer-
again and say that, we're grateful that in our country, we at least have a bowel cancer screening programs. There are several countries in the world where they do not have structured screening programs like we have. You have options to pick for, like Dr. Park said, the best test is the test that gets done. And to remember that all of these other tests are two-step tests. They are colon cancer detection tests. Colonoscopy is the only one which is detection and prevention. So, like you all said, get the test done. That's probably the final, message here.
Great. We have a few questions from our audience. The first one is, are there any types of foods I can eat to avoid getting this type of cancer?
Well, I mean, we mentioned sort of reduced dietary quality is increasing your risk of colon cancer. So I generally tell my patients, diet high in fruit and vegetables, the diet high in fiber, avoiding red meats, avoiding smoked meats and fishes, or decreasing. I'm going to say decreasing because, I think avoidance is harder to do before you decrease. Avoiding processed foods and sugars, getting exercise, not smoking, avoiding tobacco products, avoiding overconsumption of alcohol. These are all the things you can do today to decrease your risk of colon cancer.
Great. Another question we received was, can Crohn's disease lead to colon cancer?
So yes, when Crohn's is one of the inflammatory bowel diseases, the other subset being ulcerative colitis. So yes, when Crohn's does involve the colon, there would be a risk for colon cancer, we think, related to continued inflammation if untreated or not treated adequately. So it is a risk. We think more with ulcerative colitis, as ulcerative colitis always involves the colon. Crohn's may, typically involve most commonly small intestine as well as colon oftentimes also, but it depends on the distribution of patients' Crohn's disease. But the answer is yes, certainly if there is colon involvement, they would also be at risk.
I would add in that the biggest risk factor for patients with Crohn's or ulcerative colitis seems to be the presence of active inflammation. So if they're having frequent flare-ups, if they're not on the right treatment, if you don't have a treatment plan to check on the colon frequently, that can become troublesome. So talk to whoever's taking care of this and come up with a game plan. Is my disease under control? How often do I need a colonoscopy? How often are we going to take biopsy samples to check? These are things that we do offer at all of our locations. So having that discussion is important.
Very good. And another question we received, if there's a family history of stomach cancer, is a colonoscopy required at an earlier age?
So for stomach cancer specifically, there is no guideline that is out there that would recommend a colonoscopy based on that. Now the question would be more so an upper endoscopy. Would that be indicated? So that, it's a very individualized decision or guideline, I suppose, or recommendation. So it depends on the family history. Usually for upper endoscopies, we do these to look in the esophagus, the stomach, and the small intestine. Similar concept to do as a colonoscopy, except we're, of course, going through the mouth. We usually are doing this for symptoms, whether it be acid reflux, issues with swallowing, abdominal pain, nausea, vomiting. So certainly if there's a family history of stomach cancer, I would definitely recommend discussing with your healthcare provider to see if you may be indicated to also get an upper endoscopy. So that can also be done sometimes the same day as a colonoscopy if there is an indication. So we are able to do that in the same visit where patients get put to sleep or sedated one time. And so yes, certainly that is more so based on symptoms and any individual risk. So if any question about that, again, I wouldn't hesitate to discuss this with your healthcare provider.
Great. That's all the questions that we have time for today. What message would each of you like to send to someone who is over the age of 45 who hasn't been screened for colon cancer?
I would say make an appointment to come in and talk about it with us if you're on the fence. We can show you what the preps look like. We can show you what the center looks like. I mean, we, believe it or not, we love what we do. We like doing colonoscopies. We like taking care of our patients, taking out polyps and, preventing colon cancer. So whatever it is, whether it's the prep or the procedure or just not being sure that you want to go through with the colonoscopy and maybe wanting to do other non-invasive screening tests, we're here. We're happy to talk about it with you and then make a decision together. So like Dr. Iyer and Dr. Park have alluded to, the best test is the test that is done. That's what we want. We want you to screen and then we can decide sort of what's more appropriate for you based on whatever conversation you may have.
I think we've also become, it's become with Chadwick Boseman, with Jay Monahan, with all of these celebrities who've come out with their disease, disease diagnosis. It's become more human. You can put a human face, and that there's a person behind it. Katie Couric revolutionized this when she went live with her colonoscopy. More recently, Ryan Reynolds did it. We all understand it's not, it's not something that you want to talk about, but we are there to talk to you about it. Our friends, our families, all of us get the procedures. I get asked every gathering that I go to, I get asked about this question. And, I say the same thing. Get the test that you feel fits best to where you want to be today, but get something. Invest in your health. Get screened. Screening saves lives.
Right. And I just to echo all of that. I mean, the only thing I would add is just, getting screened for colon cancer is one of the best things you can do for your health and for yourself. But it's important to remember, it's also not just for yourself, it's just for your family, for your loved ones. So everyone just please get screened, as it could be a life-saving procedure.
That wraps up our broadcast. Thank you, Dr. Iyer, Dr. Okoji, and Dr. Park for joining us today. And thank you to our viewers for watching and asking questions. We will answer additional questions in the comments after our broadcast. If you or a loved one would like to schedule a screening with one of our providers, please visit our website, capitaldigestivecare.com. We'll see you next time.